So he's now 1 year, 4 months. He's a male baby. And the past history is he started from Patna, which was in April 14th, and he was admitted in Patna Hospital. At that time, he was 6.5 months old and his weight was 5.6 kg. He reported to the hospital with vomiting since 1 month. So they actually reported after 1 month of, trying to probably treat him at home, maybe with oral medicines. We don't have that history with us. And he also had loose motions for 4 days. And they reported when he had 17 episodes of loose watery stools overnight. So that's the time they actually got him to hospital. And he was hospitalized at Patna Hospital. They found on admission his blood pressure was low, 70 by 46 mGHD, and urine output was 240 ml, and he was obviously dehydrated. He presented with pinpoint hemorrhage, which was present all over the body, and he had an edematous right hand. Complete stool examination, which was done over there, confirmed the presence, it was greenish color, and also had mucus and pus cells at that particular time. So taking the symptoms and his blood reports showed low platelet counts, raised SGPT, and normal renal function tests were there. Culture showed E. coli gram-negative with a total count more than 1 lakh. The diagnosed MAZE was, I think, quite obviously acute gastroenteritis and septicemia. So they treated him on those lines. He was managed on a battery of antibiotics. I've not recorded them here, but I had them. They were all IV antibiotics. They gave him a cocktail of about 3 to 4 antibiotics as per the culture sensitivity report. He was NBM and had RT aspiration. They managed him on IV, that's all. So he was managed on IV. Vomiting improved with treatment after about 5 days, but loose motions continued even after 2 days after the onset of the treatment. He was there for 1 week. You've seen he was given injectables. I've written part of them. Even Fesatin was there, and Metrogen, and Flox, and Pantocid, obviously, and MSET was also there. So all that, but they found that he was really not improving. So they just took LAMA, and these are the parameters there, which show the hemoglobin of 8.7, RDW 22, platelet counts, of course, 270, neutrophils 52, lymphocytes 40, RBC, calcium 5.1, and C-reactive protein was 22, which obviously shows that he has an acute infective serology. Albumin at that time was not so bad at 3.5, but not seeing the improvement. This is the weight chart that shows obviously he was already below percentile. They discharged him and they reported to a Lucknow hospital on 21st. That was after a week's admission in Patna Hospital. In Lucknow, he was received in the cachexic and lethargic condition with feeble pulse with no bowel sounds. That was on 21st of April. His weight recorded was 6 kg. And I feel there was weight inaccuracy probably going from one center to the other. They were not so accurate. I think he would have dropped more weight since he was 1 week without any nutrition except IV. The investigations revealed hypoalbuminemia, anemia, deranged sodium and potassium levels. Sodium was low and potassium was elevated. Raised C-reactive protein and deranged coagulation profiles. The diagnosis continues was obviously E. coli sepsis with thrombocytopenia. The blood culture again here grew E. coli, which was managed with IV fluids, antibiotics, and intermittent blood transfusion was also given to him in Lucknow. Baby responded to given treatment. Feed was initiated but stopped immediately after a day due to continuous aspirate. Platelets and PRBC, that's packed cell blood cells, then the platelet poor plasma, then the intravenous hemoglobin was transfused in view of the baby's condition. So all that was given to him there, but he did not show much improvement. So again, it was LAMA from there, and though he was vitally stable, but the RT aspirate continued. He had 200 ml RT aspirate, and he was referred to a Delhi hospital after 10 days of treatment. So partially treated, but again didn't show improvement in his actual symptoms that he was having of vomiting and loose stools. He reported to another multi-speciality hospital in Delhi, where he was there for another week, which was from 3rd to 7th, and the second admission, which was from 11th to 27th. So he had 2 admissions. The first admission just primarily was to get his diagnosis done, but in between they discharged him before the reports were received of the biopsies. He when he shifted to Delhi, the reports again revealed thrombocytopenia, deranged hemoglobin, albumin was now low, globulin and raised C-reactive protein. So these levels remained high throughout his 3 hospital shiftings. The complete stool examination were again greenish colored stools, presence of mucose, pus cells, and presence of non-digested food. It also showed little red RBCs in the stools at that time. Awaiting reports, he was started on anti-tubercular drugs as his family history of tuberculosis was there. So he was given on a trial medicines of anti-tubercular. With the antibiotics, he was initiated. A biopsy was done here in this hospital, where duodenal mucosal biopsy was done, which showed superficial erosion and ulceration with separately present neutrophilic debris. Focally increased lymphomononucleus with admixed histiocytes were seen. Cryptus and crypt abscesses were seen. And the impression and the diagnosis now made was primary duodenal Langerhans cell histiocytosis. So over here, it became diagnosed that he has this LCH, and then lymph node biopsy was also done, which also suggested that there is a granulomatous reaction by the histocytes. Child was started on chemotherapy, which was vinblastine, which was the first line of treatment with steroids on 12/5. So after a week, his treatment was initiated. The anti-tubercular drugs were gradually withdrawn. Chemotherapy was initiated with steroids. While on chemotherapy, he again developed febrile neutropenia. In view of which, septic workup was sent along with blood culture and his antibiotics were again upgraded. Blood culture grew Enterobacter, therefore antibiotics were continued as per sensitivity pattern. Again, the culture was done for total 14 days. An injection, flibrastin, was started due to persistent neutropenia. This is to increase his white blood cells. Chemotherapy was held for 1 week. TLCs got better and his fever settled with above management. So wanting to now take you back to what actually, this was his history where he went to 3 hospitals. They kept treating the symptoms, but they actually only diagnosed him nearly after a month of going from pillar to post. And they were, of course, Patna was not so this thing, but even Lucknow was a good super specialty hospital. And then coming back to Delhi, he was diagnosed. But the line of treatment here also was the first line of treatment. So I'll tell you here also what his journey was. But first to tell you what this disease is, let's just take you through this. Now that he was diagnosed with LCH, it's a type of a cancer that can damage tissue or cause lesions to form in one or more places in the body. It can be either focused or it can also be multifocal. LCH is a rare cancer that begins in the LCH cells. LCH are a type of dendritic cells which fight infections. They are antigen presenting cells, also known as the accessory cells. The main function of these cells is to process antigen material and present it to the cell surface to the T cells of the immune system. They alternate as message between the innate and the adaptive immune systems. So they are an important part of the cells, fighting cells. These are the dendritic cells which fight infections. So these are the ones that get infected. In Langerhans cells, HCL, excess immature Langerhans cells usually form tumors also called granulomas. In 15 to 20% of these cases, Langerhans cell histiocytosis affects the lungs, liver, blood-forming systems. Damage to these organs and tissues may be life-threatening. So it's a very life-threatening disease. The gastrointestinal tract is usually involved, which in this particular case, it was the entire duodenum and the pancreas that was in sort of with a disease. So it was a huge involvement of the GI in this particular case. And bleeding may be presenting the GIS complication in LCH, and the gastrointestinal symptoms are entirely non-specific. So obviously with his diarrhea, they just sort of treated his diarrhea, not realizing he had an underlying etiology which was not getting diagnosed. In some cases, there is a lung involvement, which appears as swelling of the small airways and blood vessels of the lungs, resulting in stiffening of the lung tissue, breathing problems, and obviously increased risk of infection. So this is fatal once the lungs get involved. The hemopathic involvement, which occurs when the LCH cells crowd out blood-forming cells in the bone marrow, leads to a general reduction in the number of the blood cells. So in this case, he also had this initial issues. Signs and symptoms normally include swollen lymph nodes, which was there, abdominal pain. He did not have yellowing of skin and eyes, delayed puberty, protruding eyes, dizziness, irritability, and seizures. He had one seizure only, but otherwise, and irritable, of course, he was with all the problems that he had. About 1 in 50 affected individuals experience deterioration of the neurological functions also. Epidemiology, LCH, it's a rare disease. That's how this got missed and diagnosed in the other centers. The estimated annual incidence ranges from 0.5 to 5.4 cases per million persons per year. Approximately 1,200 new cases per year are reported in the United States. It is seen to be more among whites than persons of other races. So it's very rare for the Indians to be getting it. The frequency is greater in males. He's a male child with a male to female ratio of 2:1. So it's more or less double that. And it affects patients from neonatal period to adulthood, although it appears to be more common in children between 0 to 15 years. So this child got it at the age of about, even before 6 months. Reportedly, approximately 4 cases per million population. The age at onset varies according to the variant of the LCH as follows. Localized eosinophilic granuloma occurs most frequently in children between 5 to 15 years. Pulmonary LCH is more common during the 3rd and 4th decades of life. So he did not have a pulmonary involvement. Etiology, the cause of LCH is unknown in most cases. It is not hereditary from what everybody says. Somatic mutations in the BRAF gene have been identified in the Langerhans cells of about half of the people with LCH. Somatic gene mutations are required during a person's lifetime, which means they are required after conception and are only present in certain cells, not all. They are not germ cells, that's eggs and sperm. They are not passed on to the next generation. So obviously they are not genetically there. They are not inherited. The BRAF gene provides instructions for making a protein that is normally switched on and off in response to signals that control cell growth and development. So this is how this disease progresses. Somatic mutations cause the BRAF protein in affected cells to be continuously on and to transmit messages to the nucleus even in the absence of these chemical signals. The overactive protein may contribute to the development of LCH by allowing the Langerhans cells to grow and divide uncontrollably. The protein produced by BRAF gene is part of the signaling pathway known as the RAS-MARC pathway, which controls several important cell functions. This pathway is a chain of proteins in the cells that communicate a signal from a receptor on the surface of the cell to the DNA in the nucleus of the cells. This was discovered in the cancer cells, basically. So this specifically RAS-MAP pathway regulates the growth and division of cells, the process by which cells mature to carry out specific functions, cell movement, and the self-destruction of cells. So this is the pathway, and the chemical signaling through this pathway is essential for normal development before birth. Prognosis is not too good. The clinical course of LCH is variable. Patients with unifocal disease have an excellent prognosis, but multifocal LCH has a high mortality rate. The prognosis in these patients depends on the patient's age, extent of the disease, at what time we actually catch them and treat them, when how early can we start and initiate treatment is very important, and the degree of the organ dysfunction. So it depends on which particular organ is affected. The mortality rate is 50% or even higher. So 60% of these patients with multifocal disease have a chronic cause. 30% of these patients undergo complete remission. So we have that little hope for this little child. And 10% of patients with multifocal LCH die from the disease. Response to chemotherapy in the first week, induction therapy is among the first most important prognostic indicators of multifocal LCH. A good response to chemotherapy during this period is associated with significantly improved survival. So this child was treated with the first line of chemotherapy. These were his parameters in the other hospital, in Delhi hospital, where his hemoglobin was 9.2. But see, his albumin here now became 2.8. So having no treatment, no nutrition over 3 weeks, when he went from 2 hospitals, we found his parameters really bad. His sodium was 127. As I said, his electrolytes were deranged. His potassium was elevated. So his sodium was very low when he came into this hospital. I've taken all these reports from the other hospital. I requested them because I knew somebody, so I could get all the reports from the other hospital before he came to Apollo Hospital. So they started him on DRIS treatment. This was the discharge summary. They started him on chemotherapy, which was the first line of treatment. That was vinblastine with steroids. And it was 1.5 mg in 100 ml over 30 minutes. I want to tell you why. Then they also, obviously because he couldn't tolerate, they put in a jejunostomy. Patient was started on, he was NBM from 3rd to 20th. So that's nearly 3 weeks where he was there. He was NBM. And patient was started on TPN and TNA peri, providing 13 gram proteins and 620 calories for 17 days. This was his hospitalization in a Delhi hospital. Target was 120 and 2 grams of proteins. So they did want to start on that. And then on 21st, they started him on Altera feeds. So this was to initiate orally. 1 scoop 6 hourly was giving him about 90 grams and 2 gram proteins along with TPN. And this gradually increased it to 10 ml per hourly. Cabevan was given. Then orally, these modified feeds were also tried to increase. Total energy proteins were for 354 and 16 grams. And the feed was modified to 1 scoop for hourly, giving 130 and 3.2 from the Altera feeds. And 29th, they stopped the TPN and they stopped the jejunostomy and sent him home on oral feeds. Now, this is what should not have, I think, been done, because his oral intake was very poor. He couldn't tolerate, and he was probably just consuming a few spoonfuls of this. So this was again a 3rd admission, which was a relapse. So the line of treatment over here also should have been the next line of treatment. He did not respond to the first line of treatment of chemotherapy. So he had a relapse of the disease. It became worse, and he got readmitted with multiple vomiting episodes, which were non-bilious and non-projectile. He had complaints of loose watery stools again, poor oral intake, because obviously the child was not too well. So his weight dipped down to 5.25 kg from 6.4. So within this short period of 2 weeks, he lost about a kg of weight at home. Investigations on the 3rd admission revealed high CRP levels, blood cultures were negative, IV fluids and other supportive treatments were initiated. They did a gastrographin study and the CT abdomen to really understand where the things were wrong, because he had been initiated on the first line of chemotherapy. The CT abdomen showed extensive lymphadenopathy involving the right parapancreatic. So his involved, the entire pancreas was also involved, and the mesenteric groups. So he had an extensive disease in his duodenum and his pancreas. The gastrographin study did not show a mechanical obstruction, but however showed impedance at the level of the gastric outlet. So obviously he was not being able to digest those feeds. So the gastrographin only proved what we were trying to find out. He also had fever with chills, which was managed with medication. Not being happy with, again, a relapse and the way things were being managed, this child reported to Apollo Hospital after taking the first course of treatment there. But over there, he was admitted here now with vomiting and loose stools. He was kept NBM. On 18th, 10th, we did want to start again with NAN-PRO, which we wanted to do. But he again vomited on 19th and he was kept NBM. 20th started with clear water, but even that he could not sort of tolerate. So TPN was initiated and he was kept on TPN for at least 2 weeks, and vomiting persisted. Energy and protein through Cabiven at 20 ml per hour was 532 and 16.3. So initially we did try, but did not work out. So the diagnosed patient came over here. He got admitted for intestinal obstruction. So this is when we took over here in Apollo Hospital. His admission weight recorded was 6 kg. Liver core biopsy showed patchy macrovesicular. So again, the weights maybe, I think, because of the different weight scales were there. But lymphnode biopsy was obviously suggestive of LCH, which was now confirmed diagnosis. He was kept on chlorpheniramine from day 1 to day 5, and then he was continued feeding from 23rd 10th. He was now 1 year, 22 days. His height and weight was 6 kg and height was 64. His respiratory rate was 22 per minute and his chest bilaterals were clear. As you can see, his weights and heights were below the percentiles. Signs and symptoms at admission in Apollo showed grade 4 malnutrition. There were loose motions and vomiting, low weight for height and muscle wasting, nutritional edema characterized by swollen feet, face and limbs, and his development milestones were delayed. He's still not walking. And obviously he had hypoalbuminemia and anemia was also there. So you can see his albumins have gone down to 1.9 and his sodium was again 127, though his potassium was elevated. His calcium was on the borderline. His phosphorus was high and magnesium was 2 and hemoglobin was 9.8, but RDW was 17.6. So it shows his anemia site. These were the medicines that he was started over here. And going to the oncology recommendations, what we should have done for this child, we need about 20% extra calories to his energy needs and proteins needs by much as 50%. Poor related dietary treatment may necessitate, of course, multivitamins, and fluid status should be assessed and monitored to ensure proper hydration. These are the cancer oncology group recommendations for pediatrics. Goals for medical nutrition therapy, I think we all know. Try and sustain and promote normal growth, reverse malnutrition because he was really malnourished, he was on grade 4, prevent future malnutrition, and to promote normal eating behaviors, and then obviously may give him quality of life. These are the dietary recommendations on pediatrics oncology patients by Cape Town 2009. Which says energy needs should be more than 120 to 50 calories per kg body weight, and proteins should be 2 to 4 grams per kg, and beyond 1 year at least RDA and another percentage extra. Fats 30 to 50% of the non-protein energies, and more than 2 years is 30. Fluid infants were 120 to 150 ml per kg. So he was obvious. Then once he was here, he was 1 year. So he would fall into the category of 90 to 95 ml per kg body weight for his fluids to monitor. Since he was so malnourished, we had to really initiate very, very slowly, because anything higher would have given him a refeeding syndrome. We all know what refeeding syndrome is, which is defined as potentially fatal shifts in fluids and electrolytes that occurs in malnourished patients, especially when the albumin levels are low. So when you have a person with a low albumin level, start at lower and then gradually increase, rather than be very enthusiastic and start off on a higher side just because you feel he's malnourished, because he would have refeeding syndrome, and this child also had it, though we did try with very small volumes, but he did have diarrhea and we had to stop. So long-term undernutrition causes gradual loss of the skeletal muscle mass. This is the refeeding syndrome. That's the functional tissue and total body stores of biological catalysts. Overfeeding a malnutrition patient adds to the physiological burden by increasing cardiac output and respiration, and without sufficient micronutrients. So if you're giving a very high calorie proteins and you don't make sure if the micronutrients are also given with those feeds, it can precipitate serious hypokalemia, hypophosphatemia, and hypomagnesemia. So that's the importance, not only for children, even for adults. When you're doing it, make sure that the feeds also have the micronutrients, and that's the importance of doing nutritional scientific formulas rather than just doing kitchen-based to give calorie proteins. So when we are doing that, just be very careful to avoid the refeeding syndrome. Prevention of refeeding also ensures that we start slowly at lower than the calorie levels and then gradually advance. So this is what we did in this particular case. If you can see that we started with just 5 ml per hour with NAN-Pro, and we were trying to give him 90 calories. And we did not want to start him with parenteral, but the child continued to have greenish stools and he was very irritable, and he again was vomiting. So you can see after 2 days we had to stop the feeding, though the NJ tube was there, which was taken out once he was from that other hospital in Delhi. They had removed that and started orally, but over here we inserted the NG tube, and we also had to stop the NG feeding on the 3rd day. So then he was put on TPN and he was given Cabumin at 20 ml per hour. So we achieved about 300 calories with a 6.3 gram proteins, very, very low even with that. Then he gradually increased the TPN to 25 ml per hour, and calories increasing to 665 and a 20 gram protein. Very gradually increase was there. On 28th, we started with the oral intake again. So 27th, the NJ was discontinued. On 28th, we again initiated the oral intake. Very, very slow. And NG feed at 10 ml per hour with NAN-Pro again, and Cabumin parenteral continued. Then we increased the feeds again 20 ml per hourly with NAN-Pro 3, and we achieved about 750 calories and a 17.4 gram proteins. But he started tolerating these feeds. The main aim was to just make sure that the gut was again sort of functional, and every day we increased gradually, and NJ feed again continued at 10 ml hourly with NAN-Pro 3. On 3rd, we increased it to 20 ml 3 hourly. So with TPN, we were giving NJ at 20 ml hourly. Again, NAN-Pro 3 was the formula of choice over here, though in the other hospital, they had given Altura. They wanted to use that for the formula there. Here we did NAN-Pro 3. And he was now passing dark greenish stools even now. So he continued to have the symptoms, though the chemo had been now initiated. His stools became better on 5th. And NJ was 20 ml per hourly. MCT oil was introduced to increase his calorie density. And the consumed amount increased to 1100 calories with a 25-gram protein. So the intake was better. Now he was taking orally. Also, a little oral intake so also initiated, which was small amounts. That was barely maybe a few spoonfuls by eighth. So he looked better and was alert of his surroundings. So there was a marked improvement in his alertness, in his response. So so this was the last visit. He was discharged on NJ and oral feeds, and he got admitted for the next chemotherapy session. At this time, he was on oral feeds, but due to intolerance, again he was shifted to NJ feed 50 ml second hourly with Nanpro 3. He was continued on the same volume for 3 days, discharged again on NJ. His weight gradually improved to 6.5 kg, and the NJ tube was removed. He did it himself in the OPD, and he was advised oral with lactogen and high protein sauces through diet orally. So at this at this visit, he was started again his next chemotherapy session. The chemotherapy here was of the next level. They were not giving that. It was chlorpheniramine and injection. Neutrophine was given to him for his RBCs. So that was his treatment over here. His hemoglobin improved on his second visit. It became 11, and his albumin improved to 3.6. And you can see all his other parameters are also more stabler than before the visits, though his phosphorus also showed good. In the next follow-up, we really don't know why, but his hemoglobin again went down to 7.7%. And he came for his next chemotherapy session. There was no edema, vomiting, or diarrhea. So that way he was stable. His weight showed 9 kgs. So this was a real nice marked improvement in his weight gain. His milestones, of course, are delayed. He sits and he eats a little with a little help, but he's still not walking. And his hemoglobin was 7.7, and they gave him a blood transfusion over here. 24 dietary recall. He's now totally on oral food intake, which we obtained from the mother. He's given lactogen and given soft foods, encouraging more frequency, and paneer and yogurt. He takes a little fruit, likes to eat his chips and biscuits in betweens, and trying to encourage more and more of natural foods. Doctor is very keen to do more natural foods. This particular consultant is very, very focused on giving natural foods rather than giving protein supplements. We did start him on albumin, Venki's albumin, but he didn't tolerate it. He had diarrhea immediately. And even now, when we do try to give the albumin, the child doesn't like it. So in fact, he vomits. So we just stopped trying it anymore on him. So he's more focused on normal foods and proteins from natural foods. And he's now doing better. And you can see his growth chart. His weight gain has improved, and his child percentile is now on 34.5. He's tolerating his chemo well. He's on this is the little baby now. Doesn't look, absolutely dehydrated or malnourished at this point. Playing with one biscuit, and he's taken away the bottle from the sister's hand. He pulled it away. And this was sterilized, I hope so. He's trying to put it in his mouth. So this was his last visit here. And this is his third chemo. They are planning to give 6 chemo, the post-4th chemotherapy, sorry. And this is him now at this particular point. So it was a long journey for him without actually getting diagnosed. And then after he's diagnosed, the choice of chemotherapy that was given, he did not respond to. And it is a known fact that LCH does not respond to the first line of chemotherapy. He has to be given the second line of therapy. So once he came here, they did put him on that second line of therapy, and he responded to chemotherapy. He started tolerating feeds. TPN was gradually then withdrawn. But initially for about a week, 10 days after his admission here, after his chemo, the doctor felt that he would not be able to tolerate. So they waited for the regression so that the disease gets better before initiating NGPs. So that was and they normally respond. So that's the way he responded. The moment he responded to chemotherapy, he could tolerate his feeds orally. And that's been the little journey of this child who's been away from home six months. When he left Patna, his parents are still in Delhi, and they keep getting admitted for his chemotherapy. So till his chemotherapy is through, they're going to be here in Delhi. It's been a long battle for them, for this little child who's now 1 year, 1 year, right? 1 year. He's October born, so no, he's 1 year, 4 months. So it's been a long journey from 6 months to here.